If you would sit down again, then we'll open up now to a panel discussion for the two presentations. And I think one of the important things that came out of both of these presentations is Jacques emphasized the fact that insurance system, if you don't have a service delivery side, aren't worth very much. You know, you can insure people, you can guarantee their services, but if at the end of the day when they have insurance they can't go and get quality care, this isn't worth very much, and they're not going to continue going to those insurance programs. Dirk has really emphasized the flip side of that, and that is that you can do a PPP, you know, a lively hospital and whatever have you, but at the end of the day, if the patients going into that PPP are becoming impoverished because they don't have protection against the cost of those services, then they're no further off than if they were having the lousy quality public services where they couldn't access anyway. So these are really two sides. We need to find a way to bring these two sides together so that you have a health service that has both the social protection side and the quality services. So let's at this point open up to the group for some debate and some discussion on these two very provocative presentations.
Please, when you have a question or a comment, start by saying who you are.
My name is Max Kopolse. I have a question for Dirk. Can you elaborate a little bit on the way this PPP was structured in terms of governance, ownership, management responsibilities, and also benefits for the partners that were part of this PPP?
Let me step back 1 second. Just to use this question to make one more comment, right? So a lot of times when we talk about PPPs in healthcare, the question that comes out of Western Europe predominantly is, you're probably talking about the PFI stuff that the UK does and that some European countries are doing, where essentially the private party comes in and rebuilds the hospital, maybe puts in equipment, but leaves the government to keep running the clinical side of the business. This is a model that is that's sort of to finance as an alternative finance instrument for infrastructure investments that we don't see, I think, much appetite for really in Africa or in many of our client markets, nor would we see a lot of justification for it because you know, what's really missing is the ability to manage a hospital, to actually retain staff, to actually manage the clinical side. It's actually much less the infrastructure that's relevant. So specifically, the Lesotho project is structured as a full-service PPP. So the company Netcare that comes in out of South Africa is going to essentially build a hospital and staff it and run it entirely at their discretion and under their complete control and management for a period of, I think, 20 years plus some extension opportunities. They will take on government staff. So there is a provision for them to be able to take on government staff and government staff to choose to go to that hospital if that works out. But essentially, they're going to be providing the entire service package for a defined list of care modalities. They are going to be required to seek accreditation actually in South Africa. So we'll probably talk about this afternoon a little bit. But they're going to be required under the contract to obtain this accreditation, I think 2 to 3 years into the contract. And if they don't get it, it's a cause for potential termination of that contract. And they will be reimbursed over the lifetime of this contract by annual payments, by sort of a global budget type payment essentially, that compensates them for the cost of care and the cost and capital cost of the infrastructure assets underlying that care.
Okay, thank you very much. One more question, because normally the devil is in the detail. The government staff in this structure, is it still under the hierarchy of the department where it was taken from, or is it, let's say, part of the staff in that partnership?
In that case, they're going to be part of the staff of the Netcare. So they're going to fully transfer. But it's a good point. It's a critical point. I just want to flag this a little bit. I think one of the key reasons why government don't shift easily to health insurance is because they have to keep paying their staff, right? So there's this legacy cost of the existing systems that the governments and donors have set up. So.
You actually beat me. One of the things which, I'm Stuart Whittaker from South Africa, we're very actively involved in the Lesotho project. In fact, the company I work for, the Council for Health Service Accreditation of Southern Africa, is the company that has been granted by the World Bank a 15-year accreditation program, which has been funded to ensure that standards are maintained. And so Netcare certainly doesn't have carte blanche, which I need to correct you about. Right from the start, even at this point, we are negotiating with Netcare. The 5 clinics that are already there are already trying to implement the quality standards, and this is crucial. One of the things that's distressed me a little bit this morning is there hasn't been, although there's been a discussion about economics, about infrastructure, about technology, there hasn't been enough focus on ensuring that quality is maintained right from the start, that people understand quality standards, safety standards, and that this is an initial component of any contract. Because it's all very well, you see, and I've a fairly amount of experience in Africa, masses of money is spent on things like infrastructure, like technology. And what you find very often is that you go into a facility and there is Japanese equipment with Japanese instructions, which nobody can read because they can't read Japanese. The kind of electrical conduits don't match up to the local conduits. It's absolutely essential that these kind of things are looked at and are in place. With regard to the staffing, I can tell you what's happening there. Netcare have fired a number of people who worked for the Lesotho government because they're not good enough, and they've reappointed staff. So all of these things are quality systems which are being introduced now, not later on, because later on is too late. If you're building a hospital and you don't build in good quality assurance mechanisms like infection control, with different systems for dirty and clean products, you can't build it up later. So all of this money that's going in, please people, look at quality from day one.
Thank you.
Doreen Mulder. In these PPPs, we have had some PPPs in the West, and they're now slowly emerging into other countries. And you say yourself you started in Lesotho and India and want to see whether it's applicable in the rest of Africa. Looking at the rest of Africa, and maybe especially in the countries where the government is maybe less reliable, and you need a long-term contract with them, and maybe the legal system doesn't allow that. How do you see the role of the local government there, and compared maybe to the role of donors, international donors in PPPs? Who is the public in these contracts?
So from our point of view, this is absolutely the local government. Okay. So you know, the fact of the matter is, I think the point you mentioned is one of the critical success factors of any PPP we do. So the projects that we fail on are the projects where the government is not sufficiently committed, and that's going to be the challenge to take this into Africa. I think the donor community has a bunch of tools to mitigate some of these risks in terms of guarantee instruments, of honoring the contracts, for example, that the government enters into, but that's going to be a very tricky part. But you know, the flip side of this is, if a government is not committed to something like that, if the government is too unreliable for this, it's very hard for me to see how donors could, on the other hand, provide equipment or buildings or subsidized interest rates in the same markets, because essentially, those are just the outcomes of the lack of commitment. So I think that's what Thorsten, his presentation this morning was very, very helpful. Ultimately, if a government is not committed, it's going to filter through to the high interest rates. So if I'm going to solve it at the interest rate end, then I can also do it at the government end, or I'm just fooling myself. So but for us, it's the government commitment. The government has to really manage this contract for 20, 30 years, so they're going to be absolutely in the driver's seat on this. If a government is too weak to do this, then it's going to be very hard to pull off a scheme like that. Governments in Nigeria, governments across Africa have entered into PPPs for infrastructure projects, for IPPs, for other things for many years. Okay, so it's true, this is a risk, this is a challenge. There's some instruments to mitigate it, and I think there's principally finance sources that go in alongside these projects.
I'm Peter van den Hamburg, and I'm GP and policy advisor for the Dutch Association. And I have a question connected to the question of this, my friend from South Africa, about the quality. It's assumed in all these economic models that health is such an easy thing as cars or other things you purchase as a buyer, and that the quality of a car or something like that is much more transparent than health. And we know from the United States, etc., that spending a lot of money, you don't buy good health care. You see, the States has the worst health indicators from the developed countries. So there's a problem there with and I think that problem also exists in Africa. We all know that if you have health workers that do unnecessary tests, do unnecessary treatments, do unnecessary diagnosis and overtreat people, that you just don't buy a bad car. And if you have no clue about what you're purchasing, then you can build a nice new hospital in Lesotho, but then you still may have a problem. So the problem is, how do you get these health workers doing the right things at the right moment? And it's not only the accreditation that will help, but I'm actually asking you as economists, what sort of payment system for these people would you suggest that would make them offer the most valuable health care? Could you give an answer to that?
I think there's a difference between health and medical care. Health is something that can be brought about by improving water, sanitation, and this makes a huge impact on health. So it's really important that you distinguish between health and medical care. The other thing is that in answer to the kind of questions where people overprescribe, where they use the wrong technologies, there's something called evidence-based medicine, where people have, over the years, developed clear protocols of what should be in place, and standards can be set which ensure that doctors have the credentials and are able to provide what their contract says they can provide. So there are definite methods which are in place which can ensure that evidence-based medicine is delivered and that medical care is practiced in the best possible way. And the only way you can ensure this is by making sure that there are things called medical audits which look at outcomes and which are monitored on an ongoing basis and are specific for the particular environment in which you're working. This is a new science, and it's really important that this is integrated and part of every system.
Thank you.
Thank you.
Sorry to interrupt you, but I want to go to Mr. van der Gaag.
Nobody wants to answer this question, I guess. I don't think economists can give you the one right answer. There's an enormous amount of studies being done whether fee-for-service, better capitation system, or whether fee-for-service under global budgeting, whatever combination of payment systems you use. Mostly those studies were done with an eye on how the cost of care could be cut in rich countries. How can we prevent those doctors from doing things just because they want to make money? And on the other hand, how can we prevent them from not doing anything under a capitation system? So I don't think that there's an economic answer to that. And I think a combination of standards, protocol, also working conditions. You probably know better than I, but many of those doctors and nurses have to work under most terrible circumstances. They don't have the drugs they want to prescribe. They don't have the tools to do their job. So a whole combination of rules, regulations, good working conditions is probably the only answer I can come up with.
I would like to echo the comment on quality. Absolutely. So I mean, we're very pleased to have you there in Lesotho. So there was a point in having you there, right? So. And I'm very happy that you're so passionate about this, because it gives us a tremendous amount of comfort. So the truth is, in many of in actually all of our PPPs, we're going to try to build some accreditation plus additional quality control measures into it. I completely agree that there is tools available, right? So they're not always used. The truth is, many of the requests from African governments to us to structure PPPs come on the back of an investment program that some donor has launched, and is a half-finished hospital with some old equipment sitting there, and they say, can we somehow operationalize it with a private sector guy, right? So I completely echo these points. On the payment, the truth, same thing. So this has been studied excessively for the US, for Europe, the shift to DRG systems, the incentives that provides. Global budgets provide, in theory, sort of an incentive to ration care, right? So because essentially, but probably not a strong one to over-provide, which is why the Lesotho government was comfortable with it. This requires a discussion with the government, with the client, as to what incentives they're comfortable managing potentially, right? So none of these payment structures are perfect, and we have to sift through them and find combinations that make sense for that project in particular. How it filters through to the individual doctors, though, is a different question, right? So. I can just say for many of our Indian projects, where, for example, the government has also forced that the public facilities get impaneled under these various insurance schemes. None of them have really worked to create incentives, because that question wasn't solved. Right? How do funds that accrue to the hospital filter through to individual doctors, and how is that structured? That's a very tricky question. The truth is, a company like Netcare has experience in that space. We can guide some of it to the extent we want to guide it in the terms of the contract, but fundamentally we are comfortable leaving this to the control of an experienced industry partner.
It's already 1 o'clock, and I think have to move to lunch. Maybe one final question, and then I give Alex the mic to close the section.
Hello, my name is Joyce Brown. One of the vital and often neglected aspects of healthcare is preventative care, especially when considering the increasing burden of chronic disease. There are tremendous strides to be made by focusing on preventative care. I was wondering, will this be a part of the PPP strategy? And if so, how do you propose to incorporate it?
So we are, and I just want to echo basically various other comments. Okay, this is new stuff. Okay, pushing this PPP idea into these very difficult markets and going down to secondary primary care. It's cutting edge stuff. We are working and we are experimenting as we go, and we're trying to create as much evidence about what works and what does not work along the way. I think your question plays a little bit to the compensation question. So to the extent that you can have structures where someone is compensated for health indicators in a certain catchment area, that person has some incentive to actually try to do preventative care, to the extent that the contract is long enough, and to the extent that you can actually control information and you have sufficient baseline data and stuff like this. Much of that does not apply in Africa, frankly. Okay, so it's going to be very hard to structure anything into these types of contracts other than just activities for them to undertake, right? So you can obviously say, do education campaigns about nutrition and this and that, which is sort of what we do with NGOs today, maybe sometimes, which sort of doesn't really work. It's hard to see what would be different under the PPP than in that situation. Because it's something that the basis in terms of information, in terms of incentives by people to comply, it's really not clear. We need more information about this. We'll probably try to include some of these things in the in various contracts and just see how it works and see what works and what doesn't. But we don't have an answer at this stage.
So in closing, I think we've heard a pretty convincing discussion and argument this morning that the age of the silver bullet is over. We're not going to solve development problems by any one disease approach or any one health systems approach. It's not going to be solved by health insurance by itself. It's not going to be solved by PPPs alone. So we're really into an era of integrated health systems and integrated systems development. And I think one of the things that Ono and his group did do in his new paradigm paper was to show how developed insurance systems really rely very heavily on developing the infrastructure and service side in parallel to that, because patients that have insurance coverage, if they don't get good services next year, they're not going to make their contributions. So I think as we move into the afternoon, maybe these are some of the issues that we should be looking at more carefully. And once you get too many cogs in this machinery that have to sort of connect with each other in order to make the machine work, of course that machine becomes very complex. And I think this is the area that we're working in right now, is to try and make these things work in such a way that you have all the parts working together. And that's not always easy, because it's very easy for one or two of those parts to kind of fall apart and not work properly.